So welcome everybody. Believe it or not, this is our 53rd webinar series from UCD. So we're over a year's worth of delivery of webinars, and there is no less interest in them. In fact, we're still getting a lot of positive feedback from you. Thank you very much. And a lot of suggested topics that you'd like us to include, today's being one of them. And so we're delighted. I'm Fiona McNicholas, child psychiatrist, with my colleague Blonid Gavin and Nora Zalaji from UCD. We're delighted to continue to host these webinars for you. Please feel free to send questions in through the chat function or at the end, because this is a clinical topic and many of you that have registered specifically today for it are very much working within the clinical realm. Let me know if you would like to have a clinical discussion, unmute and pose the question yourself to our speaker. So I'm delighted to welcome Dr. Aileen Whyte. Aileen is somebody I've met, I don't know for how many years, but I was just saying to her, I always associate her with America, although she is Irish, except she has left us for a little while again. Aileen did her BA in psychology in New York City College. And afterwards, she went on to do her PhD in clinical psychology, also staying within New York. And then finally coming back for postdoctoral clinical work to the Cork Trauma Centre. More latterly, Aileen took up a special area of interest in eating disorders, and for the last few years has really been very active in this area clinically, but also at a developmental level, and has been one of the lead rollouts in the training, the delivery, the overseeing of the National Clinical Training Programme of Eating Disorders with regard to FBT, family-based treatment for youth with eating disorders, particularly anorexia. And so we've lost Aileen, but to no better place than Stanford to join with colleagues like Jim Locke, who was the founder of the FBT model. And Aileen is assistant professor over there, involved in leading the outpatient programme of eating disorders, and I'm sure involved in their research activities as well. So today, Aileen is going to talk to us about a topic that many of us clinically have come across, and that is the increased instance of eating disorder and how that might relate to either COVID or the quarantine. Thank you very much, Aileen, for coming and presenting to us.
Thanks, Fiona, and thank you for having me. I was just saying to Fiona before we started that it's 8 a.m. here in California, but I realize it's 4 p.m. on a Friday afternoon for you, and I'm very glad that people even made the time to come along. It's perhaps not the best time. Very good to be here, and as Fiona said, I am actually Irish and in California now, but worked in Ireland for many years. So I don't know who's on this call, but I may know some of you. So I am, as Fiona said, I am director of the Eating Disorder Clinic at Stanford, which is a child and adolescent eating disorder clinic. And we are facing the same challenges that many of you in Ireland are facing now, with an increased incidence of the number of presentations of eating disorder cases. So I'll talk to you a little bit about that this morning. I also, because I am a supervisor in family-based treatment for eating disorders, I supervise quite a lot of clinicians in Ireland who are treating people with eating disorders. So I do get to hear every week. I meet groups of people, so I do get to hear about what's going on in different CAMHS clinics around the country in terms of eating disorder presentations. So I'll know a little bit about what some of you might be experiencing. Okay, so I guess that's probably enough of an introduction. I wanted to start with just doing a very brief overview of eating disorders, diagnosis and treatment. I imagine many of you are not eating disorder specialists. Probably you're familiar with this already, but so I'll just do it quite quickly. Eating disorders, these really are the eating disorders that we see in clinical practice. So these first four: anorexia nervosa, the restricting type, which is what people are most familiar with; anorexia nervosa binge purge subtype, which was a newer subtype in DSM-5, atypical anorexia nervosa, which I'll say a few words about in a minute, ARFID. Those first four are restrictive eating disorders. And for CAMS clinics, or eating disorder specialist clinics who are treating children and adolescents, those first four are the things that we're nearly always dealing with. Bulimia nervosa is actually more prevalent in the population, but we tend not to see it in CAMS clinics. We should be seeing it because there are more kids with bulimia out there, but they tend not to present for treatment. And binge eating disorder similarly is probably fairly common, but we don't tend to see it in CAMS clinics. I would always say to you that if you are attending a lecture or listening to somebody talking about eating disorders, always ask yourself or them, which eating disorders are they talking about? Because we tend, all of us, to use the word eating disorder when really we're talking about anorexia, and not all of them. We're a bit, imprecise often around that. And also, it's a very different thing when we're talking about children and adolescents with eating disorders. That's very different to adults with eating disorders. Those are very different presentations. Our clinical approach is quite different. I have treated adults with eating disorders. I'm very interested in that too, but really all of my work is with young people. So this morning I am talking about adolescents primarily, and with restrictive eating disorders. So I wanted to say just a little bit about atypical AN, because I think I don't have hard facts. It's probably too early in the whole COVID situation to have the research facts yet, but my sense is anecdotally that we are seeing more of these cases since COVID started. So atypical anorexia, there can be lots of reasons we might assign that diagnosis, but most commonly it's young people who previously were at a higher than average weight. They may have had obesity, so they may have been at a very high weight. Then they began to very significantly restrict food or exercise in an unhealthy way, and to lose a lot of weight. And by the time they present for care, there's often very significant weight loss and often very rapid weight loss. And the more rapidly the weight is lost, the more medically dangerous that is. But at the time they present, their weight may still be above average or maybe within normal range. So in that sense, the seriousness of the illness and its associated medical risks are often missed or can be missed because they're not underweight. So that's just something that I just want to bring people's attention to. And I would say as well that young people with atypical anorexia, they've been ill a very long time, often before they present, and psychologically their illness is very advanced often. And I would say that in psychological terms, some of the sickest kids I've ever seen are atypical anorexia. So I just wanted to explain what I'm talking about there. And the other thing I wanted to just talk about a little bit is ARFID. So this is avoidant restrictive food intake disorder. This is a very different kind of eating disorder. And I don't think we're seeing an increase in ARFID with COVID. We may be. We see them, but I don't get the sense that we're seeing more of them. But I always want to take the opportunity to talk about ARFID, because outside of the eating disorders field, people don't know much about it. It's very specialist. This is a diagnosis that's very often missed, and that's why I always want to take the opportunity to mention it. This typically is an eating disorder that starts much earlier in childhood, often from toddler years. These are extreme picky eaters, essentially, is what you might think of them as. They've often lack of interest in food, very low appetite, no interest in food, often have a very kind of strong disgust reaction to very many different foods. They avoid foods based on sensory characteristics. So in other words, there are kids who won't eat crunchy foods, or kids who won't eat chewy kind of foods, or kids who won't eat wet foods like curries or sauces, or they don't like their food touching on the plate. They're extremely picky, low appetite. Sometimes they develop it suddenly after something like a choking incident, and a child will stop eating entirely. But it's more commonly long-standing not eating enough and eating an extremely narrow range. They might eat like yogurt and cake and nothing else. And so these kids they have weight loss is possible, but what really is more common is failure to grow and failure to make expected weight gains. Growth stunting is a really serious risk, and we miss this often in kids, and because it's a newly recognized disorder in the last 10 years. Growth stunting is really common, and we do see, particularly adolescent males who are, 5 feet tall, and they have missed their growth windows and may never now grow. So I always want to take an opportunity to just talk about it and bring your attention to it and say, watch out for it. And then in terms of treatment for adolescents with anorexia, family-based treatment for adolescents is the evidence-based treatment. The adolescents with anorexia with FBT have recovery rates of about 40 to 50%. Now, when I say recovery rates 40 to 50%, that's in about 20 sessions. Others hopefully start to do a bit better as well after that. But nonetheless, this is the most effective treatment we have. They do demonstrate improvements in weight and eating-related cognitions. It's a very inexpensive treatment. It's once-a-week therapy, so fewer hospitalizations, lower treatment costs. They do maintain their clinical improvements 4 or 5 years post-treatment. And FBT, therefore, the clinical guidelines would suggest that FBT is the first-line treatment for adolescents with AN. FBT and the Maudsley model and FTAN are essentially the same thing. FBT came out of the Maudsley clinic, so you'll hear those different terms, but you can essentially, they're all similar. So just to say something about eating disorder treatment in Ireland, for those of you who are not familiar with it, the National Clinical Programs for Eating Disorders, this is their HSE model of care. So within the last several years, there's been huge advances in the treatment of eating disorders in Ireland, and huge efforts made to improve care and standardize care. And this is the model. We are developing specialist teams, but also improving care within the local CAMHS teams. We should have within every CAMHS team a clinician who is trained in FBT, so that every local CAMHS team in Ireland should be able to offer young people and their families FBT, people with anorexia. So that's a huge improvement, and just wanted to bring your attention to that. Okay, so that's where we were, I suppose. We were actually in a much better place just before COVID hit. We were certain in terms of treatment of eating disorders in Ireland, things were definitely getting better. And then, all right, so COVID hit. So I'm in California, so I'll talk a bit about what happened in California. It's interesting because a lot of the US states kind of ignored COVID. You might remember former President Trump talking about it being just a little flu. A lot of states carried on as normal. So Europe was going into lockdown. Ireland, I'm actually not sure if you call it lockdown. We were calling it shelter in place initially, which I think was a throwback to some nuclear era shelter in place phrase. But you guys, I think, went into quarantine in March 2020, and we followed in California about a week later. So we had the very same experience as you initially. So the shops closed except for pharmacies and grocery stores, restaurants just for takeout, car repair. Our home repair and garden supply stores like B&Q stores did stay open, which I thought was very good. Starbucks, which I thought was very funny. All the coffee shops stayed open, essential services in the US. But everything else closed as it did. You know, the businesses moved to online systems, employees working from home, schools closed. They did move to the online classes, but not until the fall term. So not until the kids went back to school in August or September. So similar, I think, to what it was like in Ireland. And where I'm working at Stanford, the mental health teams moved to conducting sessions entirely by telehealth. Some of the medical appointments were in person. Many of the medical appointments also moved to telehealth, but all of the mental health appointments moved to telehealth, which is, I think, a little different from, as I understand it, the CAMS teams in Ireland moved to a bit of a hybrid model where they did some by telehealth and some in person. We haven't done any in person essentially since March of last year. Which I'm not loving, I can tell you. We expect to be back soon. California actually has lifted all its restrictions as of the 15th of June. So we no longer have a mask mandate, everything is open. So, but people are not back to work. All the businesses are not back, and we're still not back to in-person treatment. So that's where we are here. And then just thinking about the effects of quarantine that, of course, you're all already totally familiar with. But as I just mentioned these, I want to kind of think about what this is like for young people, and maybe particularly young people who might be vulnerable to eating disorders. So, you know, fundamentally, there's that profound increase in existential anxiety. And eating disorders are really an anxiety-based disorder. There's tremendous anxiety within eating disorders. So I think that increase in existential anxiety is very significant for these kids. Then, you know, obviously the disruption to the living situations, the routines, social isolation, reduced access to their support networks, increased stress in family relationships, changes to the usual physical activity rates. I think, you know, that's for vulnerable young people with eating disorder who might develop, who are at risk of developing an eating disorder. That's very significant changes in routine and physical activity rates. And of course, for young people particularly, sorry, the loss of protective activities, right? Psychologically and socially protective activities, their sports and their music and their drama classes and the things that make them feel good, the things that distract them, all of that they lost. Reduced access to healthcare services, so kids and everybody else were not seeing their doctors in the same way, you know. Diminishment of the sense of perceived control, I think, is probably very important for anxious temperaments and for kids who would be developing anorexia. And then, you know, changing routine of meals. And lastly, and very importantly, increased exposure to triggering messages about body image on social media. So I'm sure there are many other effects of quarantine, but these are the ones I came across. And just to highlight as well, stress on relationships and, you know, what that is doing to people in the family home. This was a WhatsApp message I got in May 2020. And this would have been very funny, except for the fact it was my mother sent it to me. Anyone getting to the point where it would be okay if Jolene came and took your man. And I just wanted to remind us, do you remember there were a lot of these kind of things going around in the first few months of quarantine? Everybody was really feeling the strain. Then added to that in the US, we had the whole George Floyd, Black Lives Matter situation, protests, high feelings, stress, really profound social unrest, anger, and a sense of despair around it. I would think, you know, injustice, impotence, I think, you know, feeling of hopelessness sometimes, like this was hugely important, and it was hugely significant in the culture, but just thinking about, if you remember what it's like to be 16, say, and the things maybe that you felt passionate about, or the things you know, starting to take an interest in what was happening in the world around you, and starting to get really passionate about different causes. I think this probably did have quite an impact on our young people. It impacted everybody, but our young people especially. I think there was a sense of overwhelm about it. Because we had both the protests, and you'll recall perhaps former President Trump's reactions to the protests. So I've never seen this country so divided. And then out of that, we had that incredibly divisive election. Again, everybody is so polarized within the country. It created tremendous divisions, even within families and friend groups. There's no middle ground really. You're kind of either one or the other, pro-Trump or anti-Trump, and people don't have much respect for the other position. It's never been like this before here, never been this polarized. And then culminating in this, the whole situation of the storming of the Capitol in January. Again, huge existential anxiety for Americans coming out of this. So I think all of that has added to the distress. And then the other thing I really wanted to focus on was young people's use of social media during quarantine. So because you'll recall that I think in Ireland and everywhere else, in the early months of quarantine, there was all this chatter about using this time at home to get fit and eat healthy and all of that. And I think there was stuff about, was it 5K walks, or I don't know, there were all these different things going on about we're all going to get fit. And young people reported a significant increase in such chatter on the social media sites they use, like Snapchat and Instagram. And they're spending more time on social media, and it's all happening at a time when they have few distractions and lots of times to think about all this and few social supports. This was a survey of young people in the US in 2020. So this is not eating disorder kids, but just teenagers. Over 1,500, I'm not sure if the number's there, but it's 1,500 and something teenagers responded to the survey. And so interestingly, among teenagers who sought health information online between September and November 2020, searches on fitness and exercise information came second only to searches for content related to COVID-19, which is pretty huge. And it's ahead of searches on anxiety, stress, and depression. So kids are out there wanting to know about fitness and exercise in huge numbers. And when you see that happening, we know that then a certain number of those kids are going to end up in trouble, which is exactly what we see, right? Exposure to hate on social media, hate speech on social media is also up substantially over the past 2 years. So these people had conducted a previous survey in 2018, so they were able to compare the results. The references down below here. So they were to so an increase in hate speech. 1 in 4, so 14 to 22-year-olds say they often encounter body shaming. 29% body shaming, so very significant. Also racist remarks, sexist or homophobic comments. And then among targeted groups, so, for Blacks for racist remarks, LGBTQ for homophobic ones, they're more likely than others to be exposed to those hate speech. And the findings of the report also show that the number of teens and young adults who report they were depressed has grown significantly since 2018, which is not surprising. Now, they did not ask about eating disorders specifically because this is not an eating disorder focused survey. But what we can see is the general level of distress amongst young people is higher, depression is higher, which is a good indicator of distress. There's more hate speech and more body shaming, and we know that kids are on social media more. And so if the frequency among 14 to 17-year-olds, and when we're talking about adolescents with anorexia, that's your peak age of onset in there, the frequency of encountering this kind of content on social media has increased significantly. Racist remarks have doubled, like that's a lot. And so just think about what effect does the exposure to such comments have on the young person's self-esteem, mental health, their developing sense of self? Is there a relationship between body shame and comments on social media and the increased incidence in eating disorders that we began to see then in 2020? We don't really know, but you can imagine that all of this is playing a role, I think, in why we are seeing the increase in incidence. There is the other argument that obviously social media is very positive also in young people's lives. It's become important to them for support, since maybe even more so during COVID with the isolation, important for a sense of community and self-expression. And in this survey, they found this was true, especially for those experiencing depression. And young people with moderate to severe depressive symptoms were nearly twice as likely as those without depression to say that they use social media almost constantly. Now, what about that? So some experts say that the young people's use with depression, that the young people's use of social media is adding to their depression. Others say, well, their depression leaves them uninterested in other activities, so they turn to social media by default. This research is suggesting a third possibility, that many young people who are experiencing depression, whatever the cause, are purposely and proactively using social media and other digital tools to protect and promote their well-being. Maybe. But this is a question, does social media use protect a young person's well-being? And of course, often it does, but often it does not. And I think for young people with eating disorders, we can't be sure, because one of the things we are looking at or thinking about is, what is their social media use and the development of eating disorders? What's the relationship there? And thinking about during the pandemic, teenagers spent a lot more time than usual on social media. And what are they doing? Scrutinizing images of peers and influencers on this highly visual social media. So this has implications for experiences of body dissatisfaction and disordered eating. So teenagers, of course, are prone to comparing their own bodies to the images they see online. I mean, I'm sure we all are, but teenagers even more so and more vulnerable to that. And that comparison, could create that downward spiral in terms of body image and self-esteem, and make it more likely that they would adopt unhealthy weight control behaviors. And then also, what young people find when they go looking for fitness information online can be highly problematic. So they're likely to come across harmful thinspiration and fitspiration posts where they're celebrating slim and sculpted bodies, and even there are lots of sites that encourage eating disorder behavior. And then worse, the algorithms, of course, record online search information, and those are deliberately designed then to feed back harmful weight loss content to users, young people who are already struggling with their body image. So they're then likely to get things like advertisements for dangerous diet supplements. So this is very problematic for kids who are vulnerable to developing eating disorders. And I think there's been a lot of this going on. And then, so just thinking about what are the risk factors for ED in general. So what do we know about it? So psychological factors that are risk factors for ED. So anxiety is a risk factor for the development of an eating disorders, and particularly anorexia. I suppose here I am saying EDs, and really I'm talking about anorexia. So anxiety is a big risk factor. And of course, obviously, there's a huge increase in anxiety generally since the onset of the quarantine. Intolerance of uncertainty. So people who have difficulty tolerating uncertainty are at risk for developing eating disorders. And these are such incredibly uncertain times that you can see how that really is a factor here. The other characteristics are so perfectionistic, harm avoidant, and self-doubting temperaments are at increased risk for developing anorexia, and OCD increases risk as well, and is a co-occurring condition commonly. Those are psychological factors. But thinking about the social and environmental factors, right? And we know there are very significant, that these play a role, the social and environmental factors. So body image salience in the culture matters. So cultures that have, you know, a lot of focus on thinness, will see higher, you know, there's a relationship between the numbers of people with eating disorders. So that's social preoccupation with thinness and dieting is a risk factor. Again, this is all, both these, the body image salience on social media, the preoccupation with thinness and dieting, very much increased during COVID. Participation in activities and sports that include a desired body type. What is that? That's about things like gymnastics, ballet, dance, all dance, sports like swimming sometimes, wrestling, rowing, things where you have to keep your weight low, cycling, horse riding, jockeys, for example, things where you have to keep your weight low for the sport. And what we see, I suppose, most commonly with teenage girls is ballet, gymnastics, those kind of sports. That increases risk for eating disorders, development of eating disorders. Also stressful life transitions increase risk as it does across the board in terms of all of mental health and bereavement. So, you know, obviously any kind of stress can increase the risk for the development of eating disorders. And then the biological risk factors. First of all, dieting. Dieting in of itself is probably the major risk factor for developing an eating disorder. And then starvation, or reducing food. Starvation affects the brain and influences mood changes, increases rigidity in thinking, increases anxiety, reduces appetite. And there's strong evidence that many of the symptoms of eating disorders are actually symptoms of starvation. And starvation and weight loss may then change the way the brain works in vulnerable individuals, which may perpetuate restrictive eating behaviors and make it more difficult to return to normal eating habits. And even unintentional weight loss may precipitate disordered eating. So dieting and starvation is a huge risk factor in of itself. And we saw a lot of dieting at the start of the COVID quarantine. Hormonal changes at puberty and also later in life can confer some risk or may confer some risk. Genetic factors, definitely. We're beginning to understand more about that, but genetic factors, eating disorders run in families, there is a genetic component for sure. And also eating disorders are more common in females, but many males do have eating disorders. So those are the biological risk factors. So let's think about what actually happened us here in the US and in Ireland as well. And there isn't a lot really of research yet published on this. We're beginning to see some studies around COVID and anorexia, or, you know, COVID and eating disorders, but there aren't really great numbers. A lot of what I'm talking about is anecdotal, but from talking with a lot of people, we are seeing a very significant increase in the numbers seeking assessment and treatment. By the beginning of 2021, I was hearing anecdotal reports from different clinics where they were saying we have double the number of referrals to last year. We have tripled the number of referrals to last year. So those are for CAMS teams or for eating disorder specialist teams. Like where I'm working, we are overwhelmed with our numbers. The majority are new presentations in child and adolescent clinics. I think the majority are new patients, although we are seeing some relapse of young people who had been in recovery. In the adult clinics, they're seeing more patients also relapsing, but really what I'm seeing and the huge increase in numbers is in the child clinics and their new cases. Clinics are utterly overwhelmed by the demand, and the private practice therapy providers in the community here in California, who normally would be the safety valve when clinics are full. If we can't treat them, we refer them out and they get seen privately. All of those clinicians are also overwhelmed, saying that they cannot take new patients. So there is this, the increase is just so significant that no team can cope with it. You know, even if you're fairly well resourced as a team, I don't know how many extra any team could possibly manage to see. You know, a 50% increase maybe, but what about twice the number of referrals, 3 times the numbers? You just can't get to them. And so this is incredibly challenging. And of course, unfortunately, the significant increase in the incidence of eating disorders is happening at a time when providers are trying to adjust to providing treatment online, or the hybrid situation where they're half online and half in clinic. Treatment providers do report that providing treatment by telehealth is challenging. You know, I find in some ways it's great. You know, we're getting to see people who are living at a distance and they don't have to travel. I'm trying to be positive about it. There's good things, but you know, the reality is connectivity problems. You can't hear them. You're losing the signal. Privacy problems perhaps in your own home if you're working from home, and privacy problems in the child and adolescent's home, because you might want, you know, individual time with the young person, but they feel they can be overheard. There's a lot of that privacy issues going on in everybody's house. Challenges with working with an entire family on the screen at once in family-based treatment. You can't see everybody, and you know, it's very frustrating, or you can't hear them all. So those things are frustrating, and you know, I'm thinking about the wear and tear on clinicians, right? And then providers are themselves suffering the impact of quarantine, whatever might be happening in their own lives around quarantine, and working remotely, which is more stressful, less rewarding in many ways. It's, you know, so we're thinking now, especially after many months, of clinician burnout, and also in terms of the clinicians' lives. Lack of available childcare. People were trying to work and their children were in the house. And how do you do a therapy session when your 4-year-old or 2-year-old is running around, you know, or elder care? So clinicians are often needing to reduce their work hours and reduce their caseloads at the very time that we are inundated with cases. So how, you know, what do we do? How do we respond? I was being optimistic, and I said, you know, I put this, yes, found this thing that says you've got this, but the truth is, as they say in America, we don't got this, I can tell you. So our referrals everywhere increasing to record levels. Now, I'm in a private system here. In a public system, you know which patients you're responsible for, right? So you work in a catchment area. Those are your patients, and so you have a good idea of the level of need of the numbers of people on your wait list. Those are all your people. They're unlikely to get treatment elsewhere, and that's how many you have. And it's still an impossible number, I think, for a lot of clinics. In the private system, as in Stanford, I find it quite perplexing because we have a list of people who contact us for assessment and treatment, but those are all already seeking care in every other clinic around. So I don't know if everyone in our wait list is really going to need treatment from us, or some of them will get treatment elsewhere. We have a huge wait list. So there's no natural boundary in a private system other than the state of California, because the way licensing works for clinicians is I'm living in California, I'm working in California, I'm licensed in California, I can only treat people here. So, but it's a big state. So, but regardless of your system or your location, what we're hearing is the teams are saying, we just can't step up to treat double the number of patients, or the numbers are unmanageable. What will we do? And then this places us all in this ethical dilemma of how do we triage? How do we decide who decides who gets treatments or assessment now and who waits? How are we making those decisions? So should we see the medically sickest patients first? That's what we've gone with, makes sense. But then what's happening is I get a bunch of referrals every week. I say, this number, look, like they need to be seen really urgently, let's see those. Everybody else goes on the wait list. But as I'm seeing these urgent cases, people who've been on the wait list for 2 months or 3 months are getting pushed further and further back. So, you know, it's very unsatisfactory. And here, patients with atypical AN who may be quite unwell, very unwell psychologically, have very significantly lost weight, but at the time of presentation, they're not significantly underweight, or you know, are they being prioritized at all? I haven't got, I wish I had answers. I'm very open to hearing suggestions, but these are the dilemmas we're all struggling with, I think. What should we do? How do we do it? How do we explain then our triage decisions to parents and their patients, patients and their parents? You know, you're not sick enough. Is that the message? You know, another person on our list is sicker than you or thinner than you. And those of you who are familiar with eating disorders know how, you know, anorexia is an egosyntonic disorder. Young people pursue the illness. They frequently feel inadequate in relation to other people with the illness. It's just uniquely problematic for any patient with an eating disorder, especially anorexia, to hear they're not the sickest or the thinnest, is how they'll hear it, no matter how carefully you word that message. And it's just heart-wrenching for clinicians to have to tell, you know, desperate parents, we cannot make space for your child. And this is what's happening more and more as time is going on. And so then the other question is, how do we support our clinicians? Because it's been more than 1 year. And I would say the unmanageable level of demand is at least since last September, because there's a lag in time. So we went into lockdown in March. The kids started dieting and all the social media stuff and the Get Fit stuff. Most of those don't show up in clinic with eating disorders until August or September. But it's been going on ever since then. Inpatient units full and overwhelmed, all the outpatient teams beginning to feel overwhelmed, providers stressed, clinicians saying they're feeling overwhelmed by demand, clinicians reporting feeling pressured to prematurely finish patient therapy with their eating disorder patients who are not fully better, but not critically ill, in order to be able to treat somebody else who's sicker. And I can see both sides of that, right? The clinicians are saying, but this kid isn't better yet. But maybe somebody else who's trying to manage the wait list is saying, she's safe, you know, she's not where we'd like her to be, but she's safe, take a new case, you know? And clinicians get very, very distressed by that. And clinicians reporting things like, we're never actually going to get to all these people. And being really distressed by that, right? So, and then that was all bad enough in Ireland. And then this happened. I mean, so I don't know anything about this, obviously, about what you've all experienced with the ransomware attack. And I only just hear anecdotally what, you know, and I just think people were already at the end of their rope, you know, and then this happened. And, you know, I'm really concerned about how people are coping and managing, basically. And then, but just to mention, to finish on these kind of ideas, we need therefore new ideas for eating disorder treatment that are accessible and scalable. Now, in March 2020, coincidentally, the HSE Clinical Program for Eating Disorders launched a new mobile app for eating disorders. This was, a lot of work had gone into this. And so it just, I think, happened that it happened to be launched in March, right at a good time. Dr. Sarah McDevitt, whom some of you will know, who led the clinical program for eating disorder for many years. She led the app development group, and you know, she said that research tells us that the more the young people understand about their health conditions, such as an eating disorder, the more confident and actively involved they become in managing their health, and this in turn supports clinical care and leads to better outcomes. There's a lot of helpful information on that app for parents and young people. And here in Stanford, we at Jim Locke's team is developing a guided self-help FBT program for parents delivered on a virtual platform that, you know, I'm very hopeful about, that it might actually really help parents, and we might be able to treat a lot of young people that way. And then we also recommend this book by Locke and Lagrange, Help Your Teenager Beat an Eating Disorder. That's the FBT book for parents. The Irish app recommends that as well. Those are just the references for the efficacy of family-based treatment for eating disorders. And really that's it. I wanted to finish with that inspirational quote, which I can't see, but it says something like, on the other side of the storm, something, I can't see it, but you know.
I'll read it for you, Aileen. On the other side of a storm is the strength that comes from having navigated through it. Raise your sail and begin.
Thank you. So I wanted to sort of, what else can we do? And I say, look, there's no right way of doing this, and it's not going to be perfect, but we all somehow have to try and get through it in terms of the eating disorder treatment. So thank you very much. That's the end of mine. So
thank you, Aileen, for an excellent presentation. And you're very mean to put up that lovely view. If you had the Golden Gate Bridge in, we'd be very annoyed with you. But at least the weather in Ireland here has been lovely, so it can be Dún Laoghaire just as well as San Francisco Bay. But I think you are right in terms of ending with that. One would hope that through the challenges that we've all faced personally and work-wise in having and continuing to manage COVID, and for us in Ireland, the extra cyber attack, you know, that it will lead to resilience. However, I think there really is a very big worry about burnout and about being depleted, and maybe we can revisit that at the end. You know, we're not heroes, and this is what was said in the very beginning with COVID, you know, that if one puts the healthcare worker up there as being able to resolve and manage all of the difficulties, the increased demand, the triaging needs that you mentioned, there is a worry that people are nervous or afraid to say, I've had enough, I can't cope, because you know, that compounds their sense of ineffectiveness when they think everybody else is out there doing a good job. But thank you very much for that. I'm going to see, I don't know if Emma Clancy is still there. I know she was running on a time. Emma, are you there? Are you able to unmute if you are? I'm sorry, she had to log off. She just sent me a text. The reason was, Aileen will know Emma, and she know many of the other clinicians that work with me here in Lucena Clinic, because we run the FBT eating disorder team. And you spoke about its anecdotal reports, and you're right, Aileen, there isn't a lot of literature written yet which actually looks at the exponential increase in eating disorders. Liz Barrett and Sarah Richardson, a paediatrician from Temple Street, Liz is the child psychiatrist there, wrote about the increased numbers to Temple Street in Crumlin between 2019 and 2021. The first 6 months of the year, we saw a 4-fold increase. In Lucena here, we've seen a huge increase in eating disorder referrals, both to the specialist treatment centre, but also to the generic CAMS. And in Australia, they refer to it as anorexia outbreak amongst the paediatric admissions. So I wanted to ask you, anecdotally, it seems to be adolescents and young children where the increase has been huge, and it has been anorexia and anorexia prototype. So what is the evidence, anecdotal or not, about the increase or the change in presentations among adults with eating disorders?
There are some papers about an increased incidence among adults also. Of course, amounts, and they're not generally new presentations among adults. What they are is adults with eating disorders relapsing, mostly, as far as I can see. But I don't get the sense it's the same level of overwhelm. I think there's an increase, but not sort of double, triple the numbers, you know. Now it may be, but that has not been my impression. And so I do think people are relapsing for sure. Adults are relapsing, but what we're seeing among the young people is some kids are relapsing, but they're really all new presentations.
And again, within our own service, what we're finding, apart from the huge increase in new onset, as you said, of those that had pre-existing eating disorders, it's kind of a balance between some of them have actually improved significantly because the parents have been able to be home and actually are able to supervise the meals. And that lack of social comparison that happens by meeting up with people face to face is removed because the young people aren't doing that. So interestingly, there's been a small group that actually have found COVID and being at home and the stress that comes with going to school is hugely beneficial. And then the flip side is there's another group where, you know, the normal positive effect of distracting yourself with your peers and even putting all your efforts into the academic, you know, endeavors, because that's taken away from you with school closures, that group, it's increased significantly. So it's kind of been mixed.
Yes, actually, I think that's exactly right. Because we're inundated, we're kind of focused on that. But there are benefits. Parents being home is a benefit. It's a protective factor for a lot of kids with eating disorders because they can supervise meals more easily. Do you know, parents are working from home. So for those kids who already had eating disorders, it's protective. And it's also very useful for kids who are developing eating disorders because parents are already home. And there are kids who, a lot of kids, not so much the eating disorder kids, but you know, who were relieved not to have to go to school. There are those others for whom the loss of the sense of achievement because schools stopped here in March, so there were no more exams or grades, and for kids who really enjoy getting good grades and it matters to them, you know, it was a big loss to them. So yeah, it does vary. That's true.
Have you any ideas, Aileen, about why you highlighted very nicely the huge, I suppose, the secondary effects of, you know, the confinement, the stay at home, shelter in place and all of that on the young people. Have you any idea about why for some young people it has led to eating psychopathology and for other young people it might lead to an increase in self-harm or low mood, or yet another cohort it has led to increase in binge drinking, sometimes on their own, but sometimes, you know, with peers?
Yeah, and so that's interesting, isn't it? Is that partly due to what is your vulnerability genetically or characterologically? You know, I suppose under stress we'll all show that stress in slightly different ways. So kids who were vulnerable maybe because they had that personality style, perfectionistic, OCD, anxiety, may be more vulnerable to developing an eating disorder. Interestingly though, Fiona, and again, it's anecdotal, I would say that we think we are seeing more kids with co-occurring depression and self-harm, you know, more complex kind of cases, much more mood disorders co-occurring with the eating disorder. We feel our presentations are more mixed in that sense, so that they have low mood, self-harm, as well as maybe a binge purge, anorexia presentation, more of those kids.
One of our attendees have said they've noted an increase in social anxiety. And I was wondering whether Anne-Marie meant in the eating disorder cohort or in general in the adolescent. Anne-Marie might like to qualify, or feel free to unmute and make that comment.
Fiona, thanks for that. It's just, I would say to you that very like what you're seeing, Aileen, that noticing a huge, it's like rising tide of anxiety has brought the baseline of what people were tolerating up a level, so that now we're getting a manifestation of a lot of mental health difficulties that might have been absorbed traditionally just through the adolescent period. So I'm seeing quite a lot of young people with early onset eating disorder in the community, also early social anxiety, which I wouldn't have seen previously. So just your comments about that, Aileen, thanks.
Yeah, it's interesting. So, and I think that possibly is affecting us all. What an extraordinary thing. We were all removed from our lives all at the same time. And then there was a kind of well, now you have to go back. And I'm seeing among adults a reluctance to go back to the workplace. But what happened with the kids is the schools opened up. Now in California, when the schools opened up here in around April this year, March or April, most schools gave kids the choice about whether they wanted to go back or not. So they could do it at home or they could go in. And I was thinking, oh, thank God the schools are open and this is great and it'll be so great for the kids and they'll all be so happy to be back. And I was quite fascinated that at least half of them chose not to go back. Now, the vaccines are widely available here and have been. So, you know, everybody who wants the vaccine has the vaccine. Like they're like pleading with us to get vaccinated. I was in New York recently and they were giving out vaccines on the subway. I'm not joking you. They had like, they've set up booths and stuff and they're like, are you vaccinated? Do you want a shot? You know, so vaccination is not the issue. But so many young people did not go back to school. And when I was talking with clinicians in Ireland where the kids went back to school, I think in April this year, but there wasn't this offer of a hybrid place. It was just like, go back to school, I think. And you can correct me if that's wrong. But what we were hearing is so many kids being incredibly anxious about going back to school, actually, not having been with their peers for so long. Kids who previously hadn't been anxious about going to school had developed a lot of social anxiety and were, you know, really struggling. And so the eating disorder kids started to have a very difficult few weeks again as they struggled to go back to school. So, you know, I just think that it's quite normal if kids are taken out of their environment, that some of them will become quite anxious then when asked to return. I don't know.
Has there been, Aileen, has there been any work done on that cohort? Because it's fascinating, as you say, that half opted in and the other half out. Is that related to, you know, the comfort and the support of being at home, maybe with parents that can work easily from home? Is it the child's choice or the parents' choice for ease of, you know, navigating, commuting and everything? Is there any sense that it's higher or lower socioeconomic kids? Is there any research done to look at that?
There's none I know of, and it's interesting. I can only tell you from working with patients that I was like, oh, are you back to school? And they're like, no, I'm not going back. Often they choose not to, especially anxious avoidant types. And a lot of kids with anorexia have an anxious avoidant style. So many of it's interesting. I was kind of surprised. I thought they'd be all happy to go back, but no. So, and you know, they've lost touch with friends sometimes, or, you know, their relationships with friends have occurred entirely over social media for a year. And you know what it's like communicating on social media. It's not, so friendships have changed. They are anxious.
Aileen, switching it a little bit, Eliza Dooley asked a question about ARFID and what is the prevalence of ASD within ARFID, and maybe to talk a little bit about if it's not ASD, well, what then is the typical profile of a child with ARFID?
So a lot of ARFID kids are, what do we call them, neurodevelopmentally diverse. So they look a lot like ASD kids, and there's quite an overlap between ASD and ARFID. But the one thing I would say to you is that a lot of the ARFID kids have sensory issues and rigidities and all kinds of things, but we try not to be too quick to talk about ASD or diagnose ASD until we have the child better nourished, because a lot of what you're seeing is actually starvation. And when they're better nourished, they may become more flexible. And so, although a lot of them look like they have ASD, what we focus on clinically is re-nourish them, figure out how to get them eating better. We usually do FBT for ARFID. And when the kid is better nourished, then you start to look at, well, is there ASD or not? A lot of them will have features but not meet full criteria.
Do you make a distinction between kind of recent onset ARFID as opposed to a child who's been a fatty eater and has just progressed into more selectivity? And
most of them are long standing. The more recent onset, something like a child might have had a choking episode or an illness or something and they stopped eating, I would have to say a lot of those kids characterologically are quite rigid or look a bit ASD anyway. But so it is different. So, you know, we still treat it, but we don't see as many of the sort of the phobia of choking kids. We see more, I would say, of the long-standing ARFID, not eating enough kids.
And in that group, you know, that have had this kind of pervasive difficulty in the variety of food that they eat and, you know, maintaining weight trajectories, is the end goal of FBT just to try and catch up on the centiles a little bit, or is it variety? Are you happy if they end up on some supplements, but their nutrition is maintained?
We are generally looking for good enough. Yeah, you're never going to make an ARFID kid a wide range of healthy food kind of eater. They'll never eat broccoli, maybe. Do you know what I mean? We're looking for better nutrition. And often when we're starting out, if the kid is very underweight and they eat 3 different foods, we say to the parents, just give them more of those 3 foods. Give them 4 yogurts. Do you know what I mean? we do work on range, but we really want better nutrition. So if a kid is really, really medically underweight, just give him more of whatever he's eating, because even that is difficult.
And so ending FBT successfully still on your 40 SIP isn't a failure. It's quite
Not
acceptable.
And we have a clinical trial at the moment for ARFID and FBT to testing its effectiveness. We're doing 14 sessions once weekly for 14 weeks. And I'm finding that really in 14 weeks, you can help a family get to a place where they're able to effectively feed their child, so better nourish their child with less conflict. And the kid is more relaxed and better able to manage it. So we may have only introduced a couple of foods, you know, but parents have got it. They've kind of got the understanding of what it is they need to do.
And in those, last question about ARFID, in those kids where it is a little bit more a phobia or kind of post-traumatic, and if you think of, you know, any trauma and re-exposure, the essential component is the anxiety before the exposure. In your new FBT model, are you actually adding in some pre-exposure anxiety reduction or not to the parents as a deliberate intervention?
We are not. We are not. And so you may find, and there isn't really an evidence base yet for a treatment for ARFID. You may find, it's a very good point, those kids are maybe a different kid, but I don't know. Kids with ARFID are highly, highly anxious about eating. And so we're helping the parents to work with them in a way that's compassionate but firm. You know, we'd often find that working with the child, that, you know, that the child knows in advance what we're going to do. Okay, this is what we're going to do. We're going to try a peanut butter sandwich, you know, and they do it bit by bit.
If I might just ask one last question, Aileen, and I realize I'm encroaching everybody's Friday evening, but thank God it is Friday again. Poor Aileen has a day's worth of work to do. But a question was asked about, obviously, the malnourished states of anorexic young people, and the fact that those may be particularly vulnerable to COVID, because they're both undernourished, but also there's a bit of literature about immunity issues in anorexic individuals, and obviously that being a risk factor for COVID also. Is there any study done on short-term and long-term consequences of having both an eating disorder? I know the answer to this, as does Barry, but I'll put it to you anyway, Aileen, on having both COVID and an eating disorder.
I don't think there's a research on it yet, is there? I haven't,
no.
But yeah, but I did have a couple of cases of kids who had COVID. But for example, we know that unintentional weight loss is a risk factor for eating disorders. So I had a couple of kids who got COVID, lost weight, and developed an eating disorder. But you know, how all of that may play together, I don't know.
Well, it may be that that our next talk, which is on the long-term impact of COVID pandemic on mental health and well-being of adults, by Eleonora Lobb, it might be that, you know, we can ask her specifically, you know, whether within that group, how does it apply to the eating disorder cohort. I know there was a recent article written, I think maybe a month ago or maybe less, by The Lancet, that about half the people that were diagnosed with COVID ended up in a 6-month follow-up getting a psychiatry diagnosis, and a significant number of them for the first time. And again, I haven't seen the detail of that to see how many of those related at all to abnormal eating. Because I know even a study, Aileen, we did recently in Crumlin, which has nothing to do with eating disorders, but we were looking at how the impact of COVID and stress has affected staff. And 44% of respondents said it had a deteriorating effect on their eating patterns, and about a third a negative effect on their exercise. So even unrelated to eating disorder per se, just exercise and eating being part of how people use it to cope or effectively or malcope. You know, it would be interesting to see a little bit more of that data. Aileen, I'm very mindful of your day just starting, and I'm delighted to all our audience members for having stayed with us. It was a fantastic presentation. I think it would be lovely to invite you back again and to talk a little bit more about FBT and the pilot study. When will the RFID pilot study be finished?
I'm not sure. It's still in progress. We're seeing patients now. So what are we in 2021? I imagine that would be next year then, by the time it's data finished.
So maybe we might put a marker in the diary for FBT and a little bit of a feedback on that, because it is a particularly difficult group, and I suppose, you know, a very varied group. So Aileen, thank you so much for the presentation today.
Thanks for having me.
Pleasure. And as you can see there from our slide, feel free to link in next Friday, Aileen, if you're up that early, and join our next presenter. So I wish all the attendees a very happy weekend. It's Father's Day for all the fathers out there. So hopefully the weather will be kind, and we look forward to seeing you all.